We're going to do massive transfusions. Those of you who weren't here yesterday, we did a little flip-flop. So massive transfusion is going to go in now. And I think the reason I think we wanted to flip-flop it is because there are these times when you will be called upon to save somebody's life by giving them a large volume transfusion. You would think the surgeons know how to do this, and you would think the emergency doctors would know how to do this. And I think there is some new information here that will probably be interesting, maybe controversial, I don't know. The idea in the past was, well, when you're giving a lot of blood, you're supposed to serially measure the hematocrit, and you're supposed to serially measure the platelet count, and you're supposed to serially measure the clotting factors kind of thing, pro-time, and et cetera, and then you're supposed to respond. So platelets are running low, you give more platelets. Clotting factors, INR's gone up, give more clotting factors, fresh frozen plasma kind of thing. However, in really massive transfusions, which they define massive transfusions as giving one blood volume within 24 hours, which really doesn't kind of meet our definition, because we're not talking about 24 hours, we're talking about what's happening in the next 2, 3, 4 hours kind of thing. So what's the average person's blood volume? 70 mLs per kilo. So the proverbial 70 kilogram person will have a 5-liter blood volume. So if you replace their blood volume and within 24 hours, 5 liters, then that's considered a massive transfusion. But we're really talking about the front end loading of this thing, where you're going to be ordering multiple units of blood because this person's got a ruptured aortic aneurysm, and it's got a GI bleed, and they're bleeding out right in front of you kind of thing, or some other source of some trauma where they're exsanguinating, that kind of thing. So this idea, this old idea that you could serially measure and then respond to it, just doesn't make any sense in terms of, I need to know what to do now. If I measure the platelet count now, I'll get it back in a half an hour, and by the half an hour, what I'm measuring it will have changed because now I'm further down into this transfusion. So the idea has been, by some, to kind of give fixed ratios of these components. And the Maryland Institute of Emergency Medical Services was kind of like one of the first shock trauma places. And they started reporting way back in the 70s about what they were doing. And they, although it's not in this first paper here, they did talk about what their ratio of like packed cells to fresh frozen plasma was. And at that time, they would, for every 5 units of packed cells, they would give 1 unit of fresh frozen plasma. We'll see that that's probably not consistent with more modern theory here about how you do this. This first paper here, which is from 1979, does talk about some of the key issues in large volume transfusions, like about establishing large bore IVs above and below the diaphragm. Do we still do that? I don't think that we necessarily do that. They certainly say give colloid or crystal. It doesn't matter, although it really does, because if you're going to give somebody blood as quickly as possible, the idea is to hang up normal saline, because normal saline is the liquid that is compatible with blood. And the colloid-crystalloid ratio, people are still wasting their time trying to figure out the answer to that, and basically the answer is it doesn't matter which of the two you use. They also point out avoiding alkalosis. You know, they took bicarb away from us in the ACLS thing. We're not supposed to use bicarb anymore, kind of thing. One of the rationales there was because hemoglobin gives up its oxygen to tissues better in an acidotic environment, and hemoglobin holds on to the oxygen more aggressively in an alkalotic environment. Although certainly in most shock states or thereabouts, you're going to be more acidotic than not. The idea that you talk about is using Group O blood. One of the things that you see at the hospital is if you're going to use it like a type-specific uncrossed mass transfusion, they go really nuts over in the pathology lab. They come over with papers saying, here, sign here, sign here, sign here, like you're really giving like plutonium or something like that to these people, and it's really dangerous, and oh my God, you know, what am I doing? I think the bigger sin, frankly, is to wait for 45 minutes or an hour for them to get a type and cross-match, whole thing done kind of thing while somebody's exsanguinating. And we'll have some papers in here that talk about what are the risks of giving O negative and O positive blood and type-specific blood. The long and short of it is that there are virtually no risks to doing that. And then there's this, they also bring up this issue about calcium supplementation. We'll talk about that issue a little bit later. The traditional mantra is that you don't need to give exogenous calcium in transfusions, but we'll show you some cases where that's not the case. They talk about cold blank blood. So the idea is here the potential for hypothermia because you're giving like 4, 5, 6 units of cold blood and put it in the blood warmer and then make it coil through and it comes out hot at the other end. The idea there is that's kind of good, but you don't get something for nothing. So the issue here is make more microaggregates. That blood basically, as you warm it up, there is these particles in the blood that are dead red cells, platelet aggregates, white cells, those kinds of things clumped together. And bags of blood have grams and grams of junk that will be showered into the capillary beds, primarily of the lungs, causing problems. And so we filter that stuff out. You make more microaggregates when you heat up blood. There's this issue about mandatory use of filters. Most hospitals require that you use a 40 micron filter when you're giving blood. They'll say, okay, if you're going to do it in the setting of some kind of massive commando transfusion, you could skip it. The 40 micron filter is the microfilter. The standard blood filter is 160 to 260 microns wide. Remember, the red blood cell is 7 microns across. So even in a 40 micron filter, you can get 6 or 7 red cells to go arm in arm through the mesh of a microfilter, although it certainly will slow down the rate by which blood goes in. And our real enemy in these cases is dilutional coagulopathy. Dilutional coagulopathy. The patient is trying to, they've got this injury, there's bleeding here and there. They're trying to get clots forming in the site of that bleeding. It's not necessarily being successful, but you're consuming clotting factors in the process of trying to stem the bleeding by your own clotting process. So you're into this issue of diluting your clotting factors because you're giving packed cells without giving adequate numbers of platelets or fluorescent plasma, and they are also, the patient themselves is trying to generate clots and clots, clots and clots, using up clotting factors. So the bottom line is that you result in a large volume transfusion dealing with trying to prevent a dilutional coagulopathy. So the message now is anticipatory delivery of platelets and fresh frozen plasma in association with packed cells. So that you don't measure, you just say, here's the ratio. We're going to give, for every unit of this, we're going to give that, that, and that. And I'll show you the papers that talk about that. Some of the transfusion basics, I asked our hospital, what do you guys pay for a bag of packed cells? And the Red Cross charges our hospital $245 for it. You donate it, they give you some cookies and orange juice and convert it into $245 and sell it back to the hospital. Packed cells, spin it down, take off the liquid component, and the liquid component's got all those clotting factors. They take that off because really what you're looking to do is, in usual transfusions, not these large volume transfusions, is just give the red cells the oxygen transporting element, and you will give more red cells per unit time and per unit volume if you give packed cells. So the idea is you got this stuff that's got a hematocrit of 65, 70% concentrated. You're giving this. That stuff has been sitting in the refrigerator. It's allowed to sit there up to 42 days, and at the end of 42 days, they say this blood's too old, because during that time, red cells are dying, and the ratio of red cells that are alive to dead kind of thing becomes an issue as the blood gets older and older. As these cells lyse, they release into the liquid component their intracellular contents. They have the wrapper, the cell wall wrapper kind of thing, basically becomes part of the debris that you don't need to be showered into you. And so the fresher the blood, theoretically, the better. The idea here is we're lysing red cells over time. Intracellular potassium is 30 times greater than extracellular potassium. So all blood that has been stored will become hyperkalemic as these red cells lyse and release their internal potassium into the liquid component. The other thing is that one of the reasons that we use packed cells, we want to get rid of that liquid component because in most cases we don't need all of those clotting factors, except in the large volume transfusion, which we're going to be talking about. But they're the source of a lot of the transfusion reactions that are not hemolytic. Non-hemolytic transfusion reactions are largely related to protein antigens in the liquid component of blood. The other reason why you want to give packed cells rather than whole blood is to get rid of the anticoagulant. The anticoagulant in the blood that prevents that bag from clotting is citrate. Citrate is put into that bag of blood along with a couple of other things. And that chelates calcium. As you chelate calcium, then blood won't clot because you need calcium in the clotting cascade kind of thing. So if you're giving a lot of the liquid component of blood, you're also giving a lot of citrate. Somebody's bleeding, you can chelate their calcium, so you're basically giving them an anticoagulant. And you may, in the process of giving them all of this citrate, chelate enough of their calcium that they become functionally hypocalcemic. So the issue was, well, do you need to give people exogenous calcium when they're giving large volume transfusion? And the answer is, in the vast majority of cases, no. But if in fact you are giving large volume transfusion, the answer may be yes, because there may be a manifestation of hypocalcemia systemically, which we'll talk about in a bit. So this blood is sitting there in the bag. They added citrate. They add the red cell fuel is dextrose. So dextrose is added. They add phosphate for ATP. They add adenine. That's about ATP as well. And they add some mannitol. Basically protects the red cells from the cold exposure that they're going to be involved in. And so that's a bag of red cells at $245. The liquid component has all those clotting factors in it, also has all of those protein antigens that is coming from that other person, which may be a source of non-hemolytic transfusion reactions. What does that cost? It costs, the hospital gets charged $30 for fresh frozen plasma, which is, it's hard to conceive that the hospital would charge something so small. But anyway, that's what our hospital is charged. Fresh frozen plasma has to be ABO compatible, but it only takes a couple minutes to determine what your blood type is. We used to do the physicals for the fire departments and the police department. And the police department always wanted us to do, as part of their physical, determine the person's blood type. Like, because when they get shot, we would go through their wallet kind of thing and say, well, let's see, a Target card, a Nordstrom card. Oh, here's your card that says your blood type. Oh, we're going to give you this right away. Yeah, sure. The only thing we were going through their wallet for is their Blue Cross card. We weren't interested in anything else kind of thing. And the fact of the matter is if we could determine your blood type in a couple minutes, like, why would we bother doing that if you got shot? And so I try to keep on talking them out of it. And they like the idea of just knowing what their blood type was. I don't know. But so they prevailed, but they were the customers, so we measured their blood type. The stuff about fresh frozen plasma has to thaw. It takes about 20 minutes. You're going to be giving a lot of it, so that may be an issue of thawing all that stuff. Once you hit a pro time or PTT of 1.5 times normal, you have substantial coagulation problem and you are behind the curve. And that means once you hit that number, for every unit of packed cells you give, you need to give at least 1 unit of fresh frozen plasma, if not 1.5 units, because you are now behind. And it's easy to get behind. Remember, 1 unit of fresh frozen plasma will increase your clotting factor somewhere between 2.5% and 5%, relatively small number kind of thing. And in these abstracts, they say 4 units of fresh frozen plasma are needed to cause any significant change in coagulation status. So the idea of giving couple units, hard to defend that. And lastly, platelets. So that they sucked off that bag of blood, they got the cells, they gave the fluid off, that's the fresh frozen plasma, and somehow they are able to distinguish the platelets and pull those off from a bag of blood. So in the old days, people used to give platelet packs, and there would be 1 platelet pack derived from each unit of blood. And 1 platelet pack would raise your blood platelet count about 10,000. And so people used to give platelet packs in units of 5 because you need 50,000 platelets there or better to have an adequate number of platelets for coagulation. So if you gave somebody 5 platelet packs, you would know that they would be at 50,000, assuming they had 0, and then, you know, they don't have 0. They got some kind of number, but it's not 0. So that was the rationale. They don't do individual platelet packs anymore. They do this platelet plasma apheresis, where they have some kind of donor who comes in and gives a lot of blood. They pull the blood out, put it into a little machine that somehow separates out those platelets, and they gave the person back all the rest. So all they're doing is seconding out the platelets out of this donor. And in that setting, you can give the equivalent of, you generate from that person, depending on what their platelet count is, a platelet pheresis pack, which is equivalent to 6 to 10 single donor platelet packs. So one person generates the equivalent to 6 to 10 units of platelets from an individual donor. So remember, one platelet pheresis pack is 6 to 10. And it relates to what their platelet count is. If their platelet count is 400,000 or 250,000, that's why there's this range of 6 to 10 kind of thing. But that's a platelet pheresis pack. What does that cost? That's $480. $480. Platelets only live 5 days. So this stuff is kind of hard to get. Blood Bank has to deliver it, get it from the Red Cross if you need it. You need to order early on, preemptively, because there's going to be some, unless you're at a really, really large hospital, your hospital won't have one of these ready to go necessarily. Blood types, O positive, 38% of the population is O positive. O negative, that's 7%. So most people are Rh positive, but it's different. It's actually interesting that there's some ethnic differences. Caucasians, 85% of Caucasians are Rh positive. African Americans, 90 to 95% of them are Rh positive, and Asians are 99% Rh positive as a group. So by far the population is Rh positive. And you can see down that list there, I think you have the same list I do. A positive and 34%, A negative. B positive is 9%. I'm one of those B positive. It's a mental attitude that's good to have, B positive, but the fact is if you need the blood, you might be up the creek. And then there's the universal donor. Donor, the way I remember this is donor, got O's in it. Blood type O is the universal donor, O, donor, O. That's how you remember that kind of thing. O. So women basically get O negative in the childbearing years to prevent them developing antibodies, which will then take out their kid when the kid is developed to be O positive. And well, let's get more specifically on the question of the citrate. So we said most papers say don't need excess citrate. Abstract number 2 describes 4 cases where these people started developing evidence of congestive heart failure, pumping power deficiency kind of thing here. So you've got this 25-year-old guy in a motorcycle accident, exsanguinating kind of thing. Next thing you know, you start to hear some rails developing. So what's the story here? Yes, they could be, because in fact you gave so much of this blood that you have now chelated their endogenous calcium, and now you have a hypocalcemic person, pumping power, the heart goes down kind of thing, manifested in. So they have 4 cases. 3 of them responded to exogenous calcium. So never say never. These are, and especially in the setting of large volume transfusion, this may be an issue. How do you measure whether somebody's calcium is kind of like their functional ionized calcium is going down? You measure the QT interval. QT prolongation on the cardiac monitor is a suggestion that this person may be becoming hypocalcemic, and this person may be one of the occasional persons that could benefit from 2, 3, 4, 5, 6 cc's of calcium gluconate, calcium carbonate, or calcium chloride, whatever. I don't think calcium carbonate would be a good idea. Fixed ratio transfusions is what this talk is really about, giving fixed ratios of blood. Abstract number 3 says, we looked at 17 people who exsanguinated, and we think that the ratio of what they should have gotten was, and I don't understand this ratio, frankly, that for every 6 units of packed cells, you would give somebody 3 units of fresh frozen plasma, and you would give them 1 platelet pheresis pack. Remember, 1 platelet pheresis pack is, for the sake of discussion here, we'll say 6 units of platelets. So it's 6, 3, and 6. We think that that's what people should get. I don't understand how they came up with 6, 3, and 6. It seems to me they ought to come up with 6, 6, and 6. But they came up with 6, 3, and 6. And using that, and they defended it in some process in this paper, they looked at 17 trauma patients who died and said, did these people get enough fresh frozen plasma? Did they get enough platelets? And they concluded that 82% of them got insufficient, one or the other or both. And I think, honestly, if you watch people's behavior in terms of the numbers that they pick of when to pick some platelets and when to pick some fresh, they're just picking numbers out of their head kind of thing. I mean, there appears to be no science to this whatsoever. And I think when that occurs, this is what's going to happen. These people they'll get into a dilutional coagulopathy, and they will be undertreated with regards to platelets and fresh frozen plasma. This paper suggests that that would happen. Now, any of you work at trauma centers? Trauma center. Now, what do they do at a trauma center? You just pick out numbers, right? High science. Well, I'll show you a couple of papers that may change how you approach this. Paper number 4 is one of those papers that says, once a dilutional coagulopathy has occurred, you are behind. And catching up, you need 1 to 1.5 units of fresh frozen plasma for every unit of packed cells. Papers 5 through 7 get into the inadequacy of treatment and what may be some outcomes. Like here's number 5. So this is a study of people who have ruptured aneurysms. And what did they do? They looked at how they did before they had a protocol, 82 people, and then they had a protocol. They looked at 50 of those people followed by the protocol. What was the protocol? The protocol says that when you have a ruptured abdominal aneurysm, we're going to give you 5 units of fresh frozen, 5 units of packed cells, 5 units of fresh frozen plasma, and we're going to give you 2 platelet pheresis packs. Say for the sake of discussion, say a platelet pheresis pack is conservatively 1. They're going to give you 5, 5, and 10. 5, 5, and 10. 5, 5, and 10. More platelets than you would really expect to get. And then they looked at the outcomes in these ruptured aortic aneurysm people when they just pulled numbers out of their head rather than when they used this fixed ratio of 5, 5, and 10, 2 platelet pheresis packs, which we're going to convert down to how many single units would be, geez, that might be a minimum of 10, maybe as high as 20. In any case, 30-day survival with the protocol, 66%, 30-day survival without the protocol, 44%. So a substantial difference, statistically significant, clinically significant as well. They teased the data a bit and said, listen, when the patient gets done the surgery and comes to the ICU for the recovery, let's look what the platelet count is when they arrive in the ICU and see if we can link that up to their mortality. The mortality was 30% if the patients, when they arrived at the ICU after their surgery, had a platelet count below 50,000. The mortality, the survival was 30%. The survival was 45% if you had between 50 and 100,000 platelets, and the survival was 69% if you had more than 100,000 platelets. So the message was, the more platelets these people had. Now this is an association, so we don't know, maybe it wasn't related to the number of platelets in terms of causality, but it suggests that, these people, more platelets they had, the better. So that basically is a strategy and we see ruptured aneurysm cases periodically. You do this commando thing where you call in the surgeons, call in the operating room team. The diagnosis is you're not really positive, but somebody fainted, and now it's a 70-year-old person. They fainted, and they feel something maybe in their belly, and they got no blood pressure. And you basically make the call that this person is dying in front of you of a ruptured aneurysm, and you mobilize all the resources, kind of thing. And you're going to be ordering blood. And I'm suggesting that one of the things that you ought to do is consider using one of these fixed ratio transfusion. And the one in paper number 5 is cool. Number 6 is postpartum hemorrhages, a really scary thing. This woman's bleeding out kind of thing. They used a protocol, 6 unmatched units of packed cells, 4 units of fresh frozen plasma, and 1 platelet pheresis pack. So that's basically 6, 4, and 6, 6, 4, and 6 in terms of, we'll say a platelet pheresis pack for the sake of discussion is 6 single donor platelet packs. So 6, 4, and 6. Why they didn't use 6 and 6, unclear. But in any case, they said we gave it a couple of patients and we think it made a difference. And lastly is this trauma exsanguination protocol, paper number 7. This guy who did this protocol was on the cover of emergency medicine ASEP newspaper, an ASEP throwaway kind of thing. There was this picture of this doctor there. And here's what happens at their trauma center. When somebody comes in and they're exsanguinating, they send over a box. And in that box are 10 units of uncross-matched blood. So that's going to be O, or you can determine the patient's blood type quickly. But this is 10 units of uncross-matched, 4 units of AB negative fresh frozen plasma, and 2 platelet pheresis packs. So this is 10, 4, and let's say for the sake of discussion, 10, 4, and 12 or 20. 10, 4. So this is like the aorta thing where they're hyper on the amount of platelets that they give these people. And when that box is done, they send over another box. And that box has got 6 units of packed cells, 4 units of fresh frozen plasma, and 2 platelet pheresis packs, which is, again, more than you would expect for somebody who's getting 6 units of packed cells. It's at least twice what you would expect. So they're heavy on giving the platelets. And then in the study, they compared 70 patients treated with the old way, where doctors just picked numbers out of their heads, with the new way using the trauma exsanguination protocol. And all of these people had immediate surgery because of their hemorrhaging process. And they looked at unexpected survivals, were unexpected survivors based on their TRIS scores with these trauma scores kind of thing. Unexpected survivors were higher, 20%, versus about 6% when they used the protocol versus they didn't. And unexpected deaths were lower, 3% versus 17% when they used the trauma exsanguination protocol rather than just picking numbers out of their head. Overall mortality, however, was not statistically significantly different, but maybe in a bigger study you would show that. So I think that this is new literature. This is coming out. This is basically saying this is, we think, the way to go in terms of using fixed ratios, not based on measuring serially hematocrit, serially platelets, serially protimes, and those kinds of things in people who are exsanguinating. Papers 8, 9, and 10 all basically tell you how safe giving O negative and O positive blood is. Studies after study after study on this says this is not a big deal. So the first paper is number 8. Here's how many? 601 units of O positive blood for people. They get no cases of sensitization of young females, but generally it's supposed to be O negative for potentially pregnant females kind of thing. 9 used 200 units of type O, 53 units of type specific. And number 10 was the largest study, 581 units of type O uncross-matched blood. Males did get positive, females did get negative here. The largest reported series. Look at, only 4 women were Rh negative in this whole series, because women don't have, they don't suffer from excess testosterone. Like this is all young trauma cases kind of thing. They're all testosterone toxic, motorcycle, alcohol, you name it kind of thing. Women have more sense than that. So the idea here is this is extraordinarily safe. These are just 3 papers. I've seen other papers. And so the idea here is it's not a big deal. It is not a big deal. Do not be frightened by all of the paperwork that's going to come over from the blood bank when you decide to give somebody a O negative or O positive transfusion, or even a type specific transfusion, because there really shouldn't be. I don't know why why people are making such a fuss over this. It's more deadly to wait 45 minutes or an hour in somebody who's exsanguinating. So what are the risks of getting an infection from a transfusion? Red Cross data, that's number 13 here. HIV or hepatitis C is 1 in 2 million. 1 in 2 million. I'll take those odds. 1 in 2 million. You're more likely to die from a penicillin shot than HIV or hepatitis C. 1 in 2 million. Hepatitis B, it's 1 in 200 to 500,000. 200 to 500,000. Again, inconsequential. It also reflects the fact that hepatitis B is much more contagious in terms of transmission than hepatitis C. It's much more easily to transmit hepatitis B. Hepatitis B basically screws up your liver. Hepatitis C does too. Hepatitis B, most people clear the virus. So 85% of people who get hepatitis B clear this virus at least, and so they can't give it to other people by blood transfusion, sex, those kinds of things. Hepatitis C, it's just the opposite. 15% of people clear this virus, so the vast majority of people who got hepatitis C have this virus, live virus around, which they can give to their partners and through blood donations and IV drug use. And I know 3 doctors who have had liver transplants as a result of hepatitis C. They got these transplants because they were phlebotomists when they were medical students, when, in the 70s and 80s, when people weren't as attuned to this risk. And so they basically got hepatitis C, and they puttered along with SGOTs that were above normal, but nothing to write home about for a long period of time. Then after about 15 years, bam, up went the liver enzymes, and they basically wound up getting a liver transplant, 10, 15 years after catching this virus. So the idea basically is it's not a good thing to have. No cases of West Nile virus have been reported to be transferred in the setting of a transfusion. Bacterial infections, yeah, you can envision that some people have bacteremia and that they're donating blood and they just brushed their teeth or something like that. We should maybe have it so you can't brush your teeth for 2 hours before you donate blood, you know, so that you don't get some bacteria in your blood. This is 1 in 33,000 people getting a, and this is from contaminated platelets, 1 in 33,000 bacterial infection, 1 in 75,000 with a platelet pheresis transfusion. So the long and short of this is consider just giving them back what you take from them. What you take from them is 1 unit of packed cells, 1 unit of fresh frozen plasma, 1 unit of platelets. And then in the more aggressive programs, they're giving 2 units of platelets for every 1 unit of blood that you're going to give them. So they're pretty aggressive. Now there's obviously not a lot of science here. There's not a lot of papers on this, but I believe that this makes sense because you'll never be up when you're giving 6, 8, 10 units of blood transfusion because you've got this case that is just going terribly and start pulling numbers out of your head. Well, I think we probably ought to give some platelets now, and I think we ought to give it. These papers suggest that's not the way to do this at all. And any of your trauma units basically kind of moving to something like this, where to just bring it over a box and say, here, give this? No? No, well, I would show them these papers because I think that this is going to be where this goes.
Had an intravascular hemolytic reaction that resulted or contributed to death in a massive transfusion I gave a guy who was dying of varicose. So I'm just wondering if you have any papers that selectively take out the populations of patients who get repeated transfusions that you have to give whole unmatched blood to when you're dying.
No. It is bad news to give somebody the wrong blood type. You know, that's bad. And it still happens. You know, it's hard to believe with all of this, you know, timeouts. You know, yeah, we're going to do a timeout in the emergency department to make sure that this is the right laceration we're suturing. You know, you go through that stuff. Yeah, this is it. That's the cut. That's it. Yeah, well, that's it. We better. So, are we reducing the right shoulder? Is this the correct shoulder? Where we just time out? Are we in the right room? Is this the right screaming patient with the shoulder looks? You know, this one size fits all. This is kind of really pretty sad, actually, for emergency medicine. A timeout. Okay, this is basically other people telling us how to do our business, and we resist because it doesn't make a lot of sense, kind of thing. And it's always these doctors are always dragging their feet. They're always resistant. Electronic medical record, do you never get with it, kind of thing. You know, they never ask us. But in any case, it's hard to conceive that people still do get the wrong blood type. But that is bad news. That is very dangerous business to do that. And you see the nurses when they're giving this blood. I mean, it looks like they're arming a nuclear submarine, kind of thing. They're reading the number back the code numbers. They got the switch flipped up here, switch flipped up, you know, the code, bang, bang, arm the submarine, kind of thing. And they still screw this up somehow. No, I understand. When people basically get exposed over and over to, yes, and one of the concerns about that is that it's not just the red cells, but it's some of these other components which are more ethereal about what is causing this reaction, kind of thing. All right.